Thank you very much, and it's a great pleasure to be here. I don't have anywhere near the sophisticated understanding of mathematics that David and many of our other speakers have, but what I do have is some clinical experience, and I like to think about data and evidence, and so that's where the topic, does what I know or think I know matter? And just briefly, I guess what I'd like to cover is, should experience matter? What is the concept of an expert opinion? To maybe have some cautionary words about being aware of what you think you know and whether that's actually true. And the I's, like what I know, is not about me for this talk. Many people know I often have an opinion about things, but I think this is about where does the clinical experience we gather fit with all the other evidence that's provided to guide our practice. And what I'd like to do is look at some of those settings over the next 15 minutes or so. And when you start to look at this, it appears all the time in our practice, and this was last week's adventure for me of trying to rationalise where clinical experience fits. So there's a 72-year-old man, he's an acute admission to the intensive care unit after a repair of a ruptured abdominal aortic aneurysm. He returns to the ICU, he's intubated and ventilated on moderate doses of vasoactive agents, and there's his chest x-ray. And I look at it and go, that central line looks pretty high. I wonder what I should do next. And then I reflected and thought, I remember what happened last time I saw this, and that didn't go so well. The fluid extravasated out into the man's neck, he got an upper airway obstruction, ended up with a tracheostomy. So my clinical experience was, I've seen this before and it didn't work very well. I think I'm going to change my behaviour and do things differently. To which one of my colleagues said, I'm not sure your anecdotal experience counts for that much. And you go, so what does the hospital policy say we should do with these lines? Is there some published practice guideline for us? Surely there must be a Cochrane review somewhere that would tell us what to do. Or do we have any large-scale randomised controlled trials? And so how should I approach this? So after I put a new line in, which is what I'd already decided I was going to do, I reflected on maybe what I should have done and how should I have approached that. And as I canvassed a few opinions, my registrars suggested I could do a Google search or tweet someone and see if I could get a bit of popular opinion about what the approach would be. Others said, let's do a literature search, let's find those practice guidelines, that your personal experience is okay, you've been around for a while, you've probably seen it before, that does have some weight. We actually, at the end result, embarked on an audit as well because we thought this might actually be a problem, we should get a bit more information. And I would say be careful about that because you might get some surprises in what you find and be left with more questions than you started with. Or someone said you should do a really big study on this, which I decided I wasn't going to embark on. Because you can actually find in the literature there is some data about the formula to put how far to put this line in, and it's known, and it seems reasonably robust in the literature, but that still doesn't tell you what to do when it's not in far enough, and it still doesn't tell you if relying on my personal experience is okay. And we all know that not all practitioners adopt experience in the same way. There are thinkers and what I'll call cowboys for the purpose of these exercises. So there are people who take anecdote and experience and they shoot from the hip. And I'm sure we all know those practitioners in our own experience. And there's others who ponder, I would say appropriately, about what to do. And I guess what I'd like to suggest is there is a healthy way to use experience, that you take your clinical experience and combine it with some appropriate reflection, that maybe you even audit your practice so you're more formally assessing your experience, and you might even get your peers to look at some of that. Those of you who complete continuing medical education programs will start to see this looks remarkably like some sort of ongoing maintenance of professional standards. You might review the basic science research around the topic, and you might review some clinical research. And what you'd come up with, hopefully, is to formulate a plan. The best approach you could from all you have to learn, from all the sources, and that counts your clinical experience in amongst it. In fact, in many professional domains, and this is the one for doctors in Australia, I'm sure other domains have the same thing, there is a code of conduct. And somewhat refreshingly, when you read that, it says that the practice of medicine is challenging, there's no guideline could ever encompass every situation or replace the insight and professional judgment of good doctors. So I thought at about that point, this is pretty straightforward. My experience is valuable and it's okay if I think about what I'm doing. Middle of this year, the local Brisbane newspaper published this story as the Toowoomba, which is a regional town here, hospital accused of underdosing chemotherapy cancer patients. And I guess by way of background, there's a national recommended guideline for palliative chemotherapy for lung cancer patients. The doctors in that hospital modified that protocol to use a lower dose. They did that because it was a conscious decision. They thought it was too aggressive for dosing from their experience, and it was more appropriate to give a lower dose. So in the 47 patients involved in the scandal in the newspaper, all of them were palliative. 37 of them were too sick to even tolerate their lower dose, so it's hard to imagine they would have tolerated the higher dose of the national protocol. And the other 10 all responded well with their scans showing a tumour shrinking. So to my reading, this actually seemed okay. But some people still questioned, what if you'd done something differently? And the official health department response was they acted immediately to move the hospital to the evidence-based protocol used by everybody else. They did say there's no obligation for anyone to use a protocol, but we moved them towards a standard that we've determined. So maybe there is sort of an obligation, at least from the health bureaucrats. So it appears that freelance medicine, even if it was well thought out, is not tolerated, and that has some pros and cons. We know practice guidelines are useful for generating a standard approach and smoothing out bumps in the road, but they might have some downsides. And the official response actually said, we absolutely want evidence-based practice, there's no question about that, because even though they did well, if they had have used the proper protocol, they might have done even better. I guess from my point of view, they left out the other question that they might have done even worse, and it's a double-edged sword. And I'm left thinking increasingly about the words of Voltaire, that the best is the enemy of good, that completing a project well is actually made impossible sometimes by striving to make it completely perfect. In fact, striving for best practice may have unexpected costs. And I guess in this schematic, there's a large difference between doing a bad job and doing a good job. And it's well worth the effort to do a good job. You may hardly notice the extra distance between doing a good job and doing a perfect job, and sometimes it's really hard to tell whether it's worth the effort, and there may even be some downsides to getting distracted from what is good practice to trying to do a perfect job. I guess that leads us to this concept of what is the expert opinion. And I'm not going to dwell on that here, but many of you will remember the debate from about 10 or 11 years ago now around the original Surviving Sepsis campaign, where expert opinion and industry involvement was clouded and it questioned a whole lot of the who are the experts and what are their motivations. What is it about this best practice? It may just be someone else's personal opinion or experience, and it's hard to know sometimes if that's any more valid than yours. With any luck, it'll be based on some of the research methods we've heard about that from many years ago when large-scale randomised trials, through other methodology, as we heard in John's earlier talk, hopefully maybe somewhere getting on some patient-centred outcomes that people actually care about, and that are meaningful to the people either delivering the care or receiving the care. That they might use things like large pragmatic trials that take all comers, apply a therapy we use every day and try and establish whether that's useful or not. But they might be smaller focus studies where you get patients with an illness that we understand, that they target therapy. It's not for everybody, but it is for the disease an individual has, and maybe we should look at those more often. That there may be some design issues with large pragmatic trials that we're currently using to try and generate our evidence base. And I often reflect that would penicillin survive the rigours of a current multi-centre RCT for the treatment of sepsis? Because I think it probably wouldn't. Not everyone who would be enrolled in this trial would have an infection, so penicillin probably wouldn't work. In those that do, they're not all going to be gram-positive infection sensitive to penicillin. Some might even be allergic to penicillin, so they might be harmed by it, and that's before you even get to what dose would you give. And so applied to everybody in an all-comers pragmatic trial, a treatment that we know is highly effective if you have infection with a sensitive gram-positive organism would be discarded into the barrel if it doesn't work. The next step of that is the meta-analysis of those results then, and that really, I think, as John alluded to, can be summarised, rubbish in and rubbish out. If there's no good evidence, that needs to be acknowledged right up front somewhere when you're trying to figure out whether you're going to interpret the results of a meta-analysis. I'll talk briefly about being aware of what you think you know. Steve Nissen from the Cleveland Clinic said that the road to hell is paved with biological plausibility. People think they know a whole lot of things that make sense biologically, and they may not be. And I think we all maybe need to take time to be honest enough to reflect on why it is you believe what you believe. Increasingly, the only thing I'm certain of is that I don't know for sure. And I think it'd be really appropriate to think about, would you have equipoise for an appropriately designed study? And I'm going to talk briefly about the START-AKI study on renal replacement therapy, where we're looking at if we can improve outcomes by administering early dialysis. And the aim is to identify people who probably need dialysis and randomise them to start it now or start it later. The final point of the entry criteria is the clinician has equipoise to start RCTs, to start renal replacement therapy, which is why I've been thinking a bit about this. So you're going to have to think about what are the advantages I perceive to starting dialysis, what are the downsides of starting dialysis, and what's my equipoise here. And I just put up one example from our unit. When might you have equipoise in someone who over 6 days had their urea go from 7 to 56 and their creatinine go from 116 to 587? And on each of those days, the clinicians looking after them were confident in their own knowledge that they didn't need dialysis yet. They haven't met my criteria. And so by the time they got to a point where then they definitely needed dialysis. So somewhere on that path there was a time where you could have reflected on what forms the basis of your beliefs. Could it be they aren't correct? Does everyone else believe those facts? And could the data from an appropriately designed study better inform patient outcomes? And I think that's a real challenge for all of us to think and reflect on what is it that's driving our beliefs, that facts don't last forever, that even when you're pretty sure your knowledge is based on facts, that knowledge might expire. Some things are more durable than others. As David said, all facts have value, and that's why history is so useful, but their context may change over time, and we need to be continually reflecting on that. And I'm just going to finish in the last minute or two about new opportunities for learning. That our hospital has recently gone to a digital system, and so we have these enormous data sets that people have been talking about that we need to start to think about what we're going to do with them. And computers are really good at some things. They're good at organisation, they're good at following rules, they're good at repeating things and not forgetting things and storing information and crunching numbers. They're not so good at empathy and creativity and judgment and inventing something new. They're good at wasting time. We know that doctors now spend a whole lot of time interacting with computers, in fact more time interacting with the computer than interacting with patients. And many of you will be familiar with some sort of clinical information system, and I increasingly am trying to figure out ways that we could use this for good, not evil, other than just wasting our time. That maybe we could embed clinical research, so where clinical trials become integrated into our usual clinical work. There are studies now starting to emerge where the choice of a treatment, where it's not known as one is better than the other, is taken out of everyone's hands and the computer makes it for you for a period of time, such as this trial and the SALT study, where the computer selected for a period of time what fluid you got, and then it changed it again in a while, and then it helped you analyse the results. So you got randomised care rather than random care. And maybe that's the ultimate way to generate evidence from our clinical experience, to begin to harness the power of data and computers and clinical information systems to help us direct practice where there's no clear path forward. That it comes with a whole lot of pros about study compliance and data extraction being automated and freeing up people to do other jobs. It comes with some cons about having different people involved in research and the quality of the data. I'd have to say our experience when we've started to query the data is it's more often a human error than a computer error in the system. So in summary, I think we should encourage the healthy use of experience, that maybe we need to stand our ground and critically evaluate if some of the external guidelines we find are in fact best practice for specific patients. I really do think that best is the enemy of good. There's nothing wrong with good medicine. And increasingly we're starting to look at some of the downsides of striving for best practice, that new technology may offer great opportunity to learn from our everyday practice. And just in closing, maybe we could reflect on what is it that makes a master craftsman. Do they have different tools? Do they have better tools than everybody else? Are they just better at using the same tools? Or do they think about how it worked before and try and do a better job the next time they do it? Thank you very much.